is Dr. Vikash, Managing Director, UV Cardiac Care Hospital, Tirupati. First of all, I would like to thank JB Chemicals for giving an opportunity to speak about this novel molecule, inclisiran, and its present role in management of ASCVD, the atherosclerotic cardiovascular disease. So we'll go ahead with the presentation. So today's presentation topic, as I told before, on expert perspectives on inclisiran, when to initiate, and who in which subset we need to go ahead with initiating on inclisiran. Yeah. So these are the key topics which we will be discussing in this presentation. So as we all know that Indians have a high CV risk and experience earlier CV events even a decade earlier than the Western population. Elevated LDL cholesterol levels are crucial due to their strong and linear association with ASCVD. So each 39 milligrams per deciliter decrease in LDL is associated with a 21% reduction in the major adverse cardiac events, which are shown in various trials. Yeah, next slide. So latest guidelines, all the ESC guidelines, the Cardiology Society of India, CSI guidelines, ACC guidelines, and also our Lipid Association of India guidelines, all the guidelines suggest to keep the LDL cholesterol as low as possible. So the Western guidelines, the ESC and the ACC expert guidelines suggest to keep the LDL cholesterol level less than 55 milligrams per deciliter. So Lipid Association of India, taking the extremely high risk of Indian subset to atherosclerotic cardiovascular disease, categorizing into extreme CV risk, various categories, suggest an even lower LDL cholesterol going to as low as possible up to even 10 to 15 milligrams per deciliter also. Yeah. So there is no significant association between very low levels of LDL cholesterol and safety outcomes. So a secondary analysis from the 4-year trial also showed CV benefits even with further lowering of LDL cholesterol levels with no safety concerns even with the LDL cholesterol below 10 milligrams per deciliter. So inclisiran is a first-in-class small interference RNA molecule used in the therapy to lower the LDL cholesterol. So it is designed in such a way that it is after administration of inclisiran, its uptake is only confined to the hepatocytes because of its specificity to the GAL-NAC, which is present exclusively in the hepatocytes. So once it enters the hepatocytes, it will go into the cytosomes, and where through its unique mechanism of action, it will prevent the formation of PCSK9 molecules so that there will be upgradation in the LDL receptors on the hepatocytes, which will result in increasing absorption of LDL cholesterol circulating in the blood into the hepatocytes. Yeah. So Indian approval also, what is the Indian approval when to start an inclisiran? So it is indicated in adults with primary hypercholesterolemia or mixed dyslipidemia as an adjunct to diet in combination with a statin or statin with other lipid lowering therapies in patients unable to reach the LDL cholesterol goals with the maximum tolerated dose of statin, or alone or in combination with other lipid lowering therapies in patients who are statin intolerant or for whom a statin is contraindicated. So suitable patient profile are it is very much useful in high CV risk individuals with the ASCVD whose high LDL cholesterol level remain inadequately controlled with standard lipid lowering therapy such as statins, ezetimibe or bempedoic acid. It is also useful in treatment of heterozygous familial hypercholesterolemia. So the recommended dose is 284 mg administered in a single subcutaneous injection on predominantly it is suggested to give in the abdomen. So stat followed by a second dose at 3 months and followed by that every 6 months once. So how if there are any missed doses, if a planned dose is missed by less than 3 months, inclisiran should be administered and dosing continued according to the patient's original schedule. Suppose if a planned dose is missed by more than 3 months, a new dosing schedule including like stat dose again after 3 months followed by every 6 months should be initiated if a dose is missed by more than 3 months. So how can we transit from the monoclonal antibody evolocumab or larosumab? So inclisiran can be administered immediately after the last dose of monoclonal antibody To maintain LDL cholesterol lowering, it is recommended that it is administered within 2 weeks after last dose of a monoclonal antibody PCSK9 inhibitor. So as we discussed before, so all the guidelines suggest the same thing only. So if a patient is having is a known case of ACS patient, so we will need to start an high intensity statin therapy like 40 mg of rosuvastatin, 80 mg of atorvastatin. If it is not under control, we can add ezetimibe to this. So we should target an LDL cholesterol level of less than 55 milligrams per deciliter at 3 months follow-up. If the level is not attained, we can suggest to go ahead with inclisiran therapy or PCSK9 inhibitors. So the CSI guidelines recommend that in patients with ACS, if the target of less than 55 is not achieved, as I told before, we can go ahead with inclisiran. So these are for the heterozygous familial hypercholesterolemia and secondary prevention. So all these suggest that inclisiran will definitely decrease the LDL cholesterol to lower levels in patients. Yeah, next slide. So same this ACC expert consensus guidelines also recommend to use inclisiran in heterozygous familial hypercholesterolemia patients. Orion trials. So Orion 9, 10 and 11, which studied Orion 9, the participants are familial hypercholesterolemia patients, and 10 and 11, they are ASCVD patients in whom study period was done up to 18 months, and all are completed studies where the dosage of 284 mg of inclisiran are matching placebo administered subcutaneously. So all the pooled analysis of all the three trials, Orion 9, 10 and 11, showed significant reduction in the LDL cholesterol level up to 50.5% and effective LDL cholesterol reduction of up to 50.7%, with inclisiran a strong complement to a maximally tolerated statin therapy. 68% of the patients achieved LDL cholesterol level of less than 70 and 52% achieved an LDL cholesterol level of less than 50 milligrams per deciliter. So in Asian patient subset also, Orion 18 trial was studied, which also showed that there is a mean LDL reduction from baseline with inclisiran of 57.2%, and there is also a significant reduction in the lipoprotein A levels also up to 41% lower when compared to placebo after 330 days with a significant p-value. So Orion 10 also showed inclisiran reduced levels of other atherogenic lipids in addition to increase in the HDL cholesterol levels. If you see here, so there is a significant reduction in total cholesterol of 33.6% in inclisiran group, ApoB of 44, non-HDL of 47, triglycerides of 14, and even lipoprotein A reduction of 21.9% with increase in HDL cholesterol of up to 7.5% when compared with placebo. So inclisiran is generally well tolerated with a safety profile similar to placebo, and there are very less number of injection site reactions in the inclisiran group, which are very mild and transient, and none were severe and persistent. So that it is known to all the studies have up to 6.8 years of exposure, and it is shown to be very well tolerated. Orion 8, which is an open label extension trial of Orion 3, 9, 10, 11 of 3,274 patients, assessed the long-term efficacy and safety of twice yearly inclisiran in patients with high cardiovascular risk and elevated cholesterol, showed that it could reduce LDL cholesterol levels in the long term and also well tolerated. So it acts in the cytoplasm of hepatocytes, as I told before, and not in the nucleus. So there is no risk of carcinogenicity and immunogenicity to inclisiran. So results from Orion 8, the largest long-term safety and efficacy follow-up with inclisiran conducted to date, showed it could reduce LDL cholesterol levels in the long term while being well tolerated, as I told before. So Orion 4 and Victorian are the ongoing cardiovascular outcome trials with completion dates anticipated in 2027. While the results are ongoing, recently published pooled patient analysis provided some insight into possible cardiovascular benefits of treatment. There was a significant 26% reduction in complete MACE compared to placebo over 18 months and fewer MACE compared with placebo. Yeah, thank you.